At the heart of tendinopathy management is progressive provocative loading or remodeling of the tendon. Provocative meaning that it's recreating the complaint that the patient is mentioning, and progressive meaning that we're adding more force, more load as needed to recreate that pain. In the overarching sense of the word, when I think about tendinopathies, there's three principles I think about. One, make sure that your tendinopathy diagnosis is correct, because I think we're misdiagnosing a lot of problems where tendons are as the tendon itself, when mechanical joint problems and other joint problems refer symptoms to where the tendons are. Repeated movement testing is the orthopedic test that can really delineate, is it a joint or is it a tendon? Because they have overlapping signs and symptoms, but that test will specify which is actually the true symptom generator. Secondly, as part of tendinopathy kind of themes, is making sure you're doing progressive provocative loading. And three is making sure you're looking for predisposing factors. They're not always present. But in some cases, especially if you're not hearing in the specific verbal history that there was a sudden increased load on the tendon or new or unfamiliar load on the tendon, if you're not hearing that, then you need to start to think, well, why is this tendon acting up if nothing really was a stimulus? Then you need to be curious. Maybe you're missing knee range of motion and that's why the tendon became dysfunctional. Or maybe you're missing neck or shoulder range of motion and now the elbow tendon is becoming dysfunctional. So those are the kind of the three main ideas. But returning to the second, which is progressive provocative loading, that means to me 5 or 6 out of 10 on a 0 to 10 pain scale. If we can't get there, then we'll make do with the smaller amount of pain that we can recreate. But I don't want to go above that in most situations. And of course, the pain can only be produced during the exercise and remain for a little bit afterwards possibly, but it cannot create more pain at night, pain and stiffness the next morning. That means we're overdoing it. There's a lot of parameters when it comes to picking the exercise that is the best progressive provocative loading exercise for that tendon. And I say that specifically because I don't want to use the word strengthening. I think people use that kind of in a lazy manner. We're not strengthening the tendon. If you test these tendons, a lot of them are strong. They're just painful. And it's pain that makes the patient not able to do the loading. And if you think about a provocative stimulus that created the tendinopathy in the first place, it's not an event where the person became weak all of a sudden. It's they took up running or they took up tennis or they were packing boxes for a long weekend. And those things don't make you weak. It just makes the tendon become dysfunctional. So I'm very precise with my words. I want people to know that we're remodeling the tendon, we're loading it, meaning putting a force through it to rehab it, but we're not technically strengthening it. So I want that to be a moderate pain, and there are different ideas in terms of how many reps or sets to do throughout the day. And I'm not beholden to one specifically. Many have been demonstrated to be effective. It's kind of what fits into the person's daily routine. If they're only able to do the exercise morning and night, then we can probably start with twice a day and see if we're getting results. But for other patients who have the time, I'm typically starting at 3 sets per day, anywhere from 10 to 20 reps, and increasing 1 set per day until we reach about 6 as the maximum amount of sets per day. Another parameter other than the number of reps and the number of sets is also, is it a concentric, eccentric, or isometric load? For me, I'm not that partial to one of them. I'm just really trying to follow the rules and being partial to the fact that we want to find a load that creates moderate pain, the pain that the patient is complaining of. So if we have a lateral tendon problem on the elbow, for example, that tendon connects to the muscles that extend the wrist. So a loading example might be doing wrist extension with the forearm supported on something with a dumbbell. It might be doing it with bands. It might be doing it isometrically against something resisting it. Or maybe I just have the patient go up by him or herself and then eccentrically load that tendon going down. There are a variety of exercises, but we have to follow the rules. We have to find that pain. We have to do a certain number of reps and sets per day. So this is a very straightforward example, but maybe someone's lateral tendon doesn't get produced. That pain doesn't get produced here. Maybe we have to rotate a little bit and then do it. Or maybe we have to rotate to complete neutral and do it this way. Whatever it takes. I mean, I find as an example in the elbow, rotation can sometimes be part of the protocol or part of the program. For example, someone may do this for 2 weeks and now there's no longer any pain, but if they rotate a little bit and then do it that way, we can get more pain. Of course, if they're doing it this way, we add more weight or more bands and they're still not getting the pain, that's an indication to keep going until you can't find any more of that pain. So it might involve a couple different movements, straight, a little bit rotated, or with a bigger grip or a smaller grip, but you want to exhaust the movements that recreate that patient's pain. Producing moderate pain, sets throughout the day, and the prognosis is at least 20% better in 2 weeks, give or take. I'm finding that for people who have more recent onset, we're going to get better results in 2 weeks. But it is a lot slower than, for example, a mechanical joint derangement, where I'm really looking for the correct movement to create 30% or more change in 2 days. So this is just a primer on how you find that pain. In the knee, for example, maybe doing a seated knee extension produces 3 out of 10 pain with 20 pounds. Maybe doing a double leg squat produces 4 out of 10 pain, but a single leg squat produces 6 out of 10 pain. Well, then I'm probably going for the single leg squat. To make it even more of a load on a tendon, you could do a single leg squat on a slant board. So there's ways to make loads on tendons more, and there's ways to make loads on tendons less. As a clinician, I'm just abiding by the rule of finding the pain that the patient is saying, yes, that's my pain, that's what I've been getting. Now, going back to the predisposing factors, again, if it's not obvious in the verbal history that a new load was what created this tendinopathy, I'm going to be looking out for predisposing factors to address them. But most times it's just, like I said, I took up running or I took up a new sport. I did something to that tendon. I used to play golf once a week. Then I started playing golf 3 times a week. Anything that's new or unusual can produce tendinopathies. And in the physical exam, there's going to be baselines that are consistent with the tendinopathy. In the verbal history, they're going to be. Do I really care about imaging for tendinopathies? No, because a lot of images like ultrasound and MRI can show problems in tendons that are perfectly functional and fine. So it really is about the clinical exam, the verbal history, the physical exam, and the testing. For me, the testing is usually going to be repeated movement testing to make sure that it's a tendon and not a joint. There isn't other kind of main tests for tendons. The big picture is what makes us think it's a tendinopathy. All those things from the verbal history and the physical exam, those will give us an idea. Yes, you want that tendon to be painful and possibly weak when you load it as a single test, but there are other things that we're looking for as well. So repeated movement testing really helps me make sure that it's not a joint derangement that we're dealing with, because again, the prognosis for that and the recovery for that is going to be on average much, much faster than a tendinopathy.